Hi, good evening everyone. Today we are going to discuss the top 25 PYQs from pharmacology. So let's get started. The first question, a 55-year-old male with a history of chronic stable angina visits the clinic complaining of frequent chest pain episodes despite taking his prescribed oral medications. The physician decides to switch one of his medications to the below given route. This is the route here, which is shown, to ensure a steady release of the drug and improve the compliance. So which drug is most likely prescribed in this transdermal patch to manage his condition? So we know that this is a patient of chronic stable angina. So for stable angina, let's discuss the management first. So either there can be an acute attack that we have to manage, okay? So acute attack. Or the second thing, after we have stopped the attack, we need to prevent any further attack. So we give drug for prophylaxis. Prophylaxis. Now remember, because in acute attack, we have to get the effect quickly. So we give the drug by the sublingual route. So we give sublingual glyceryl trinitrate or isosorbate dinitrates. But for prophylaxis, the patient can take the drug by oral route, by transdermal route, or we have the other applications here. Sustained release is also there. So which are the drugs which you can give is glyceryl trinitrate, isosorbate dinitrate, and isosorbate mononitrate. Right? So if we see the options, which of the options we see is the most feasible here? Nitroglycerin. So nitroglycerin is a drug which is given in a patch form as well. Other options, let's see. Aspirin, clopidogrel. These both are antiplatelets. Antiplatelets. But they are not available in the form of patches. No patch. Atorvastatin is a statin, and this is used to decrease the LDL levels. So it is an adjuvant treatment, not the mainstay. Adjuvant treatment. Okay, so the correct answer here is nitroglycerin. Now quickly, let's understand this nitroglycerin. What is the benefit of nitroglycerin in stable angina? How does it provide benefit? Remember, very important question, the mechanism. For stable angina, the mechanism of nitrates is that they decrease the preload because they release the nitric oxide, which leads to soluble guanylate cyclase stimulation. Then it leads to cyclic GMP stimulation or release, and it prevents the contraction. So it leads to relaxation of the blood vessels. Therefore, it will decrease the preload on the heart. Very, very important. Because it decreases the preload on the heart, it will decrease the ventricular filling pressure. Ventricular filling pressure. Because of this, there is decrease in the ventricular stretching. This ventricle will not be stretched too much, and that leads to decrease in the myocardial oxygen demand. Very, very important. So in stable angina, the decrease in preload and decrease in the oxygen demand is the primary mechanism. In contrast to variant angina, remember, in contrast to variant angina, because in the variant angina, the problem is vasospasm. So this brings about vasodilatation of the coronary blood vessels. Coronary blood vessels. And this in turn is going to increase the oxygen supply. So that is the difference between the mechanism in these two types of angina. Right? So another important thing, when we give a drug for prophylaxis, the problem is that the patient can develop tolerance. So how can we take care of that tolerance? By giving nitrate-free interval. So what happens is we should give at least 8 to 10 hours free interval. So especially at night, the patient can take off the patch, and because of if they provide free nitrate interval, therefore there will be less tendency to develop tolerance in the patient. All right, Moving on to which are the other patches or transdermal patches available and what are the uses. So it's another very, very important table. So our first one here we talk about is clonidine. Now, clonidine is a drug which is given for management of hypertension, right? So this is hypertension. But remember, clonidine has a one important drawback as well. If a patient misses a dose of clonidine, therefore there can be rebound hypertension and it's an hypertensive emergency because it leads to release of norepinephrine. So therefore the treatment for this would be alpha 1 blocker or the drug which blocks the alpha receptors, and that is phentolamine. Moving on to the fentanyl. Fentanyl is an opioid, so it is used for chronic pain. Nicotine patch is available for smoking cessation. Which other drugs can be used for smoking cessation? Varenicline and bupropion. Remember, the most effective drug is varenicline. So nicotine available as transdermal patch is also available as sprays. It is the fastest acting when one patient is suppose going somewhere and suddenly there's an urge to smoke. So the spray can be as the fastest acting way to put him off the smoking as well. Rotigotine, it is used for Parkinsonism. Rivastigmine, Alzheimer's disease. Hyoscine, oscopolamine. It is used for motion sickness. Nitrates we just discussed for the chronic angina, prophylaxis of angina. Estrogen for hormone replacement therapy. Selegiline for depression. And oxybutynine for overactive bladder. So these are some of the examples of the drugs which are available as transdermal patches. Next question. A patient taking digoxin, potassium chloride, clarithromycin, atenolol, triamterene developed atrial fibrillation. So he developed a complication or an adverse effect, atrial fibrillation with a controlled ventricular rate. The lab test revealed there are elevated digoxin levels. So the question is telling you there is digoxin toxicity because of increase in the levels of this. So which of the following medications is most likely responsible for this increase? Potassium chloride, clarithromycin, atenolol, or triamterene? So let's discuss this. Whenever you get a question on elevated serum digoxin levels, think of these three conditions. Either there'll be a drug interaction involved, either there'll be a drug which is causing hypokalemia because decreased potassium levels always tend to increase digoxin toxicity, or there'll be some renal dysfunction. So there'll be decreased clearance of digoxin. So usually these things are involved whenever a question is of serum digoxin levels. Now here, what does potassium chloride do? Potassium chloride is given and when there is hypokalemia, so it increases the potassium levels. So digoxin toxicity occurs if there is hypokalemia, not hyperkalemia. So this definitely cannot be the answer. Clarithromycin is a macrolide which is a CYP inhibitor as well as the P-glycoprotein inhibitor. So this, when it inhibits the P-glycoprotein, it has a tendency to increase the digoxin levels. We'll see how it does. Atenolol is a beta blocker. There are no drug interactions with digoxin. Right? It can cause, what does it can cause? Beta blockers can cause bradycardia. Right? But it is not, it does not have any interaction with digoxin. Triamterene. Triamterene is a potassium sparing diuretic. potassium sparing diuretic. Again, it is going to cause increase in the potassium levels. So this cannot be the answer as well. So I have told you the correct answer is clarithromycin. Now let's understand this concept. It is very important. Now, clarithromycin is a CYP inhibitor as well as P-glycoprotein inhibitor. In case of digoxin, the P-glycoprotein concept is more important because what is P-glycoprotein? It is a efflux transporter. So it is present in the intestine as well as in the kidneys and other areas. But here what we are concerned with. So what happens in the intestine, right? And let's say this is the kidneys here. So the tendency of P-glycoprotein is to efflux or throw out the drug. So if you give digoxin, it is going to throw this drug out. And in the kidneys also, the role is to throw the drug out. So it is going to increase the clearance or it is going to increase its release in the intestinal lumen. When you give a P-glycoprotein inhibitor, so this thing is going to be blocked. So what is going to happen now? Because it is not going to be thrown into the lumen, it is in the cells, intestinal cells, there will be increase in the, when inhibit this, there will be increase in the absorption and there will be decrease in the clearance of digoxin. This is the reason that there will be increase in the levels of digoxin. Okay, so very, very important concept. Now, the other question from this is, what are the other important P-glycoprotein inhibitors that we know? So, P-glycoprotein inhibitors, remember vacuum, right? Remember vacuum. Verapamil, amiodarone, quinidine, and macrolides, just like we did clarithromycin. So these are the important P-glycoprotein inhibitors. Now, another important question out of this is, what will happen if there is increase in the level of digoxin? So what are the various signs and symptoms or toxicity symptoms of digoxin? Remember, the most common is the GIT signs and symptoms. Nausea, vomiting, diarrhea, etc. It can lead to yellow vision as well, or what we call as xanthopsia. Then we have the cardiovascular side effects. It can cause AV block. So for this, you can give atropine. It can cause ventricular arrhythmias. And for this, the drug of choice is lignocaine or lidocaine. Same. Okay. And what is the antidote for digoxin overdose? So, antidote for the overdose is Digibind. So many questions can be answered from this one PYQ. These are the very, very important points. Now, we have discussed the P-glycoprotein. So let's also discuss some of the CYP inhibitors and enzyme inducers because they also form important questions. Sometimes they ask you the drug interactions with one of these drugs in the question. So which are those enzyme inducers that we have? So remember the mnemonic GPRS cell phone. Okay, so let's do GPRS cell phone. So here we have griseofulvin. Then we have phenytoin. Then rifampicin. S stands for smoking. C, carbamazepine. Then P, phenobarbital. With C, you can also write chronic alcohol intake. Okay. Similarly, moving on to the enzyme inhibitors. So remember mnemonic, sick of age. Okay. So let's discuss this. So we have S, sodium valproate, isoniazid, INH. INH is not an enzyme inducer. Remember, very, very important. It is an enzyme inhibitor. C stands for cimetidine. Then fluoroquinolones like ciprofloxacin and macrolides like clarithromycin. Even erythromycin, clarithromycin, these are all important enzyme inhibitors. Then K stands for ketoconazole. O stands for omeprazole. F stands for another antifungal, fluconazole. A is alcohol intake, but this is the acute alcohol intake. Chronic is enzyme inducer. Then G stands for grapefruit juice and E stands for erythromycin, another macrolide. So these are the important inducers and inhibitors. All right, next question. Lidocaine is used in a loading dose for the treatment of arrhythmias. The loading dose of this drug is determined by which of the following pharmacokinetic parameters. So this is basically about the formula of loading dose, whether it depends upon clearance, volume of distribution, plasma half-life, or bioavailability. So I have here the list of the important formulas that you must know. So the first formula here is bioavailability, which is area under curve oral over area under curve by the IV route multiplied by 100, because if the answer is in percentage. Remember, bioavailability will be taken into consideration, especially if the route is oral, not in the others, in IV and all. Okay. Then, volume of distribution is the amount of drug, the dose by IV route multiplied by bioavailability if it is an oral drug, divided by plasma concentration. Remember that. Half-life 0.693 into volume of distribution by clearance. Then these two have been asked repeatedly, loading dose, maintenance dose. What is the primary difference? See, in both there will be plasma concentration in the formula. The difference is one has volume of distribution and the other has clearance in the formula. F will be there if they mention that the drug is given by the oral route. If they mention that the drug is given by the IV route, then F has no role here. Bioavailability has no role there. Okay. So here, loading dose depends upon the volume of distribution. So here if we go, clearance, volume of distribution, half-life, bioavailability, the answer is volume of distribution. So simply how you can remember, loading dose has a D. Loading has a D in the spelling. So volume of distribution has a D in the spelling. So volume of distribution, loading dose. So nothing to do with the clearance here because it is important for maintenance dose only. Maintenance dose. Half-life, it is important for the steady state level. Steady state level. And how many half-lives are required for a drug to reach its steady state level? About 4 to 5 half-lives. Okay. Now, bioavailability, why? Because you see the drug here is lidocaine. We know that lidocaine has very high first pass metabolism, so it is never given by oral route. So here it is given by the IV route. So I told you in IV route, bioavailability has no route. So in the formula, though, if had it been some other drug which is given by the oral route, then bioavailability will come into picture. But if there is nothing, if there is IV drug, then bioavailability has no role. So here the answer would be simply volume of distribution. Okay. Next question is, which of the following is a competitive inhibition graphs. See the graphs A, B, C, and D. So you have to identify. Now, let's go to the answer here and tell. The first three graphs, A, B, and C, they're actually the Lineweaver-Burks plot. Okay, so easy trick to remember which graph is for which type of inhibition. Okay, let's do that. So you don't have to mug up a lot of things about this graph, only mug up which is the competitive, whether it is a competitive or non-competitive inhibition, that you have to know from this. So how can we see here? Look at the graph. In the graph, if there is a cross that you see, no, the crossing here, cross starts with a C and competitive also starts with a C. So whenever there is a cross, it means it is competitive inhibition. See the next graph. If you extend it somehow like this, it becomes a U. So U stands for uncompetitive inhibition. Now look at this, it is a V-shaped curve, right? So if you extend something like this, it becomes an N. So N means non-competitive inhibition. Just identify the graph by this trick: competitive, non-competitive, or uncompetitive. That is all. So if you see here in these three graphs, can you make a competitive inhibition? It is B. Simple. The other graph, I'll tell you, we will discuss that as well because that is also important. So how to learn or what is important in the other types of graphs. So we have log dose response curves as well. So let's do something about those graphs. So first graph I will draw here. So this is the log dose and this is the response. So this is on the y-axis and this is on the x-axis. Now here we have a drug. Let's take one drug. Drug A. So this is the response that is produced by the drug A. And here we have the dose. So let's say this is 1 milligram, 2, 3, 4, 5, 6. So this is the dose on this. Now A, and we have another drug. I'll take, let's say this one. So this is drug B. Another drug. This is drug C. Now, sometimes we get this kind of graph as well. And here you are supposed to comment on the efficacy and potency and compare these three graphs or three drugs. So how to compare? Now remember efficacy when we talk about efficacy, remember F. F is for EF, Eiffel Tower. Eiffel Tower is very tall. So efficacy is the maximum response which is produced here. So obviously this is determined by the height of the graph. Efficacy, how tall the curve has gone. So efficacy is the maximum response. So we see the maximum response of A is somewhere here, right? And then B is somewhere here and C is somewhere here. So this is the efficacy. Potency is actually the dose which produces a particular response, right? What is the dose which produces a particular response? And potency we see on the x-axis and from left to right. Okay, remember efficacy we see on the y-axis from low to above, but potency we see on the x-axis from left to right. So when the height is increasing, efficacy is increasing, but potency it is opposite. As you move from left to right, the potency is going on decreasing. So it is the opposite here. Efficacy, as you go on increasing, we'll say the drug is more efficacious if it has a higher response. But if the drug moves more towards the right, then we say that the potency is less. So it is opposite. Now let's compare these. A, B, and C in terms of efficacy. So A, you can see the response is almost equal to B, but it is greater than C. So efficacy wise, A is equal to B, but the response is greater than C. In the second one, potency. Now potency we have to see, we take a particular response because here there are different responses. We take 1 point on the response. So let's say I take this point where all the three drugs are showing a response, this one. Okay. So this is the response I am trying to compare. So at this particular response, when A is also showing, B is also showing, C is also showing a response, but let's compare the dose at which they are showing this particular response. So you can see A is showing this much response at a much lower dose, then it is B, the same response, and then it is C. I told you if you move from left to right, the potency goes on decreasing. So potency is more for A as compared to B as compared to C. So this is the answer potency wise and the efficacy wise. Then there is another graph that we get of the type of antagonism. So this is a drug or agonist without any antagonist. Now if there is a rightward shift to the right, and the same response is got, then we say that we have given a competitive antagonist. But if there is a downward shift, then we say it is a non-competitive antagonist. Okay, so remember this graph also, if there is a rightward shift, because if you increase the dose of the competitive antagonist, means they're occupying the same target site or same receptor. If you increase the dose of the agonist, the same response can be got. So that is the answer. But with non-competitive, even if you increase the dose, you can never get the same response because that site is destroyed. That's why there is a downward shift. So efficacy will decrease in case of non-competitive antagonism, while the dose, it doesn't matter, right? So potency doesn't matter. While in case of competitive antagonism, efficacy can be the same, right? So efficacy can be the same. All right, moving on to the next question. In which phase of clinical trials is drug dosing primarily determined? Phase 1, phase 2, phase 3, or phase 4? Okay, so clinical trial phases. Now let's do the clinical trial phases first, and then we will come back and answer this question. Now, we know that first, before we do the studies in the animals, in the human beings, we study the drug in the animals. That is called as preclinical trials. So after the preclinical trials are done, the reports are filed. So there is investigational new drug application which is filed. And after that, it starts with the human clinical trials. The first phase, or we can say before the first phase, we have a small phase which is called as microdosing. Now, this is not a mandatory phase. So this is not mandatory yet. So we start with a very, very small dose. That's why it's called as the microdosing. So microdosing, that means the dose is in micrograms. 1/100th of a human dose is given. No patients are there. This is healthy volunteers, a very small group of patients, of healthy volunteers. So obviously no blinding is required because they don't have a disease. This is just to obtain some pharmacokinetic information. If the drug is suitable enough to be studied further, because trials are very expensive, right? So if you want to see that whether it has a suitable pharmacokinetics or not to be able to go ahead with the trials. Then comes the actual trials, the phase 1 trial. Now, phase 1 trial is also only in healthy human volunteers. It is not in patients yet. So, very small number of healthy volunteers are taken. Obviously, no blinding is required because they are not patients. What is the main role of this? The main role is, number one, to assess the safety. Because these are not patients, they don't have a disease, so we can't determine the efficacy here. So we just determine the safety. And number two, the maximum tolerated dose. The dose can be studied here, the maximum tolerated dose. Then second, phase 2, it is about exploring the efficacy, therapeutic exploratory phase. And here you can study about the dose range. Now the patients are getting involved. So this is a patients, but in very few centers, smaller number of patients, and it can be blinding or it can be open label. So this is to determine the efficacy, because now the disease is there, you can determine the efficacy. So now we can say a new drug, let's say it's an anti-epileptic, whether it is helping in prevention of seizures or not. So, and you can tell the dose range. So now we have got the result. Yes, this drug is a good anti-epileptic. It can prevent seizures. Now what is there? The third phase, where you are going to compare it with the already existing anti-epileptic, and then see what is the difference. Is there any difference in the efficacy? Is there any difference in the safety? That is in the phase 3 trial. So here you increase the number of patients, and mostly this is blinding. They are double blinding. The patient doesn't know, the doctor doesn't know. And here we are going to confirm the efficacy. So this is the phase which is best for testing the efficacy and the safety, because we are comparing here, and that's the best phase. After phase 3 results, so let's say we have the whatever the reports are, then there is new drug application which gets filed, and now the drug is entering into the market. So now phase 4 means it is actually available to be used in the general public. So doctors can prescribe it now. This is called as post-marketing surveillance. So where what you do, the patients are there. Obviously, there will be no blinding here. You are openly prescribing the drug. So why we do this? Because and what studies are there done, especially the ADR monitoring. So in the phase 4, this is the phase where your ADR monitoring is done. Pharmacovigilance studies. Because now a wider population is being subjected to this drug. So you can even find out the rarest of the ADRs, which couldn't be possible because the other phases, they are not that long, right? And so many patients are not there. So as compared to phase 4. So you can find even the rarest of the side effects, uncommon side effects. And in special population groups also, we can see the effects. So moving back to this question, primarily the drug dosing. First, primarily, when was it determined? So you see here, the primarily it was determined in phase 1. Okay, so primary dose range, the maximum tolerated dose that we discover. So remember this. So always see the words very clearly in the MCQ. It is written primarily. Had it been dose range, then the answer would have been different. Then it is phase 3. But it is only asking the drug dosing primarily determined. So this should be your answer for this. All right. Moving on to the next question. A patient with pheochromocytoma had pounding headache, palpitations, and sweating. The blood pressure was 180 by 100 and heart rate is 112 beats per minute. So you can see very high blood pressure. The urine shows VMA and normetanephrines. MRI shows right adrenal mass. There is a tumor, adrenal tumor. Which drug will be appropriate for pre-operative control? So this is a case of pheochromocytoma. Remember, pheochromocytoma, usually we try to perform surgery on the patient, right? Surgery. But before the surgery proceeds, we need to bring down the patient's blood pressure also, so that it is easy to perform the surgery, right? So what to do? We have to decrease the blood pressure. The options given to us are clonidine, phenoxybenzamine, esmolol, and nifedipine. Now we'll see. First, let's what happens here, and then we'll come to the answer. Now see what is happening here. The tumor is secreting a lot of norepinephrine and also epinephrine. So what is happening here when lots of catecholamine released? So let's draw here. This is a blood vessel. It has two receptors. One is alpha 1 and the other is beta 2. We know the ABCD rule. ABCD. So when alpha 1 is stimulated, it leads to vasoconstriction. When beta 2 is stimulated, it leads to vasodilatation. Now, when norepinephrine and epinephrine, they're in high quantities in the body, they have a predominant, because norepinephrine has no action on beta 2, it is going to act on alpha 1 only. Epinephrine in high doses also has a prominent alpha 1 action. So this is going to cause tremendous increase in the blood pressure. So what should be the first thing that we do? We need a drug to block this alpha 1. So we have to give a drug which blocks the alpha 1 receptor so that the problem is solved. So do we have any alpha 1 blocker in the options? Let's see that. Clonidine. What is clonidine? Clonidine is a alpha 2 agonist. What is this alpha 2 agonist? It is going to act at the level, it is a central sympatholytic. So alpha 2 are the autoreceptors present, and they are going to, when it is stimulated, it's like a lock or a brake. They will not allow the release of norepinephrine. But the problem here is not here. The problem is in the tumor, right? So those tumors are secreting catecholamines. So this is not going to solve the problem. So therefore, this cannot be the answer. Phenoxybenzamine, it is a irreversible alpha blocker. So can we use this? Yes. So pheochromocytoma, phenoxybenzamine can be used. Why not esmolol? Esmolol is what? It is a beta blocker. The role of beta blocker basically in pheochromocytoma is to decrease the chances of arrhythmias. But always remember, we cannot give a beta blocker before alpha blocker. So if you give a beta blocker before alpha blocker, it is going to block this, and there will be unopposed effect of alpha 1. So there will be unopposed rise in the blood pressure. So that is very, very dangerous. So you can give beta blocker, yes, but after you give alpha blocker, then you follow it up with the beta blocker so that you can prevent arrhythmias. Also, if there is too much drop in blood pressure, because if you block alpha 1, so the epinephrine, if it is predominantly epinephrine, then it will act on the beta 2 and cause a profound drop in the BP. But then also these can be prevented if it is predominant epinephrine. If it is norepinephrine, doesn't act on the beta 2 as well. Okay, so beta blockers here. Now, what is nifedipine? Nifedipine is a dihydropyridine. It's a calcium channel blocker. Yes, it can lead to vasodilatation, but here it cannot act on the alpha receptors where the problem is there. So again, this doesn't have, it is not very effective. So phenoxybenzamine remains the best drug here option for us for pre-operative management of the patient of pheochromocytoma. So phenoxybenzamine, this is given 7 to 14 days before surgery, so that the patient's blood pressure can be brought down before surgery. It's an irreversible and long-acting drug. Other option is we can also give prazosin. That can also be given in this case. Okay. Now, what else is important? During the surgery or when we need intraoperative control of blood pressure in pheochromocytoma. That was a recent question. What are the treatment options available? So we have drugs like sodium nitroprusside. We have phentolamine, which is an alpha blocker. Now this is alpha blocker, but it is not irreversible. It's a short-acting blocker, can be given for immediate control, and we can also use nifedipine. So these are the drugs which can be given for intraoperative control. So phenoxybenzamine, very important question. So remember which drugs to give when. Next question. Which of the following statements regarding oximes and organophosphate poisoning is false? False, okay? And this is asking about oximes. All right, let's do that. They are positively charged and bind to the anionic site. They bind to the phosphorus atom attached to the esteratic site. They produce reactivation of the skeletal muscles, and their action is seen in all organophosphate poisonings. So before we come to the answer, again, let's first see what happens in what is the role of oximes in organophosphate poisoning, and then we will come back to the options and the rule out. Now, What happens in organophosphate poisoning? So organophosphates, these basically are irreversible anticholinesterases. So they will block the enzyme acetylcholinesterase. So this is an enzyme, let's say acetylcholinesterase. It has two sites. Acetylcholinesterase has two sites. One is the esteric site and the other is the anionic site, negatively charged site. Now, the role of acetylcholinesterase is that it leads to metabolism of acetylcholine. So, acetylcholine doesn't accumulate. So, that is the important thing. When you give a drug which is blocking this acetylcholinesterase and it is irreversibly blocking, so there will be increase in the levels of acetylcholine, too much increase, and that leads to all the signs and symptoms of organophosphate poisoning, the muscarinic effects, the nicotinic effects. Remember the dumbbells? So all those things, increased salivation and secretions are increased, right? So it cardiodepressant. So all those things are going to be there. So exaggerated cholinergic actions. Now, organophosphate poison, organophosphate, they bind to the esteratic site. So when organophosphates bind to the esteratic site, obviously there is the site is not free for the ester going to get metabolized. So that's how the problem occurs. Now, when you give oximes, let's say I'm giving an oxime here, oxime. So oximes, these are positively charged. So they will bind to the anionic site, to the negative charge anionic site. And in the organophosphate, there is a phosphorus bond. So this oxime is going to form a bond with this phosphorus atom and it will pull out the organophosphate from here and it will leave the enzyme free. So here what will happen now? This is being pulled out. Now the enzyme is again free. Acetylcholine, they can get again metabolized. So oximes, they are also called as cholinesterase reactivators. Okay, cholinesterase reactivators. So they are very important drugs in organophosphate poisoning. But remember, they are very effective in organophosphate poisoning. But there is another type of irreversible anticholinesterase also, which are called as carbamates. The problem with carbamates is that they bind to both the sides. So this carbamate is going to bind to both the sides. So oxime has no place left to attach. So therefore, oximes are ineffective in carbamate poisoning. So oximes can't be used here. So oximes are very important drugs, one. Now, another important thing. What is the antidote or the drug of choice for organophosphate poisoning? Is it the oxime? No. The antidote or the drug of choice for the OP poisoning is a drug which is called as atropine. So atropine does what? Atropine is a muscarinic blocker, muscarinic antagonist. Okay, it's a muscarinic antagonist. So you give it 2 milligrams every 10 minutes. Every 10 minutes till there are signs of atropinization. Right? So there will be mydriasis or there is dryness of mouth. So this is a drug of choice. Whether it is carbamate poisoning, whether it is your organophosphate poisoning, the drug of choice remains atropine. Remember this. So atropine basically takes care of the muscarinic symptoms. So what about the nicotinic symptoms? So oximes take care of the nicotinic symptoms, because what happens when there is too much acetylcholine at the neuromuscular junction, it will continuously activate the neuromuscular junction. You know that acetylcholine is responsible for the skeletal muscle contractions. But when you continuously stimulate this neuromuscular junction, it will be in a state of depolarization and not respond. So when you relieve or when you give oximes, now the excessive acetylcholine is going to get metabolized. So now there will be again, the neuromuscular junction will be reactivated again, right? So these are some of the important features here. Now, let's go back and see if we can now find our answers. Now we want to see the false statement, not the true, false statement. They are positively charged and bind to the anionic site. We saw it here. They are positively charged and bind to the anionic site. It is the correct thing, okay? They bind to the phosphorus atom attached to a steric site, yes. When they try to pull out the organophosphate, yes. They produce reactivation of skeletal muscle. Yes, I just told you the neuromuscular junction, it can be again reactivated. So yes, their action is seen in all organophosphate poisonings. Now this is the incorrect statement. Why? I told you in carbamates, they are completely ineffective. Not all the organophosphate poisoning. So not in carbamate poisoning. Remember, so not in the carbamate poisoning. Now, remember for oximes, so we have pralidoxime. So these oximes, they need to be given. They need to be given before aging of the enzyme. Remember, before aging of the enzyme. This means that with time, the organophosphates, they form a very tight bond, a covalent bond with the this enzyme acetylcholinesterase. Then, when they form a very, very tight bond here, then oximes will not be able to act on it. They will not be able to remove it. So therefore, it should be given in very short duration of time before the aging of the enzyme has occurred. So remember this point about this. All right. Now, another important table is of the antidote. So in exam 1, 2 or 3, antidotes are definitely asked in one way or the other. So we should know all the antidotes possible which have been there in the previous exams and which can be asked in the future as well. So let's study the antidotes. So the first is organophosphate carbamate. I told you that the primary drug we should always know is atropine. So first drug hamesha we have to give atropine. Then we can give oximes followed. Second is oxime because atropine is a life-saving drug. We first have to save the life. So life-saving drug is atropine followed by oxime or PAM that you can call. But remember, this is not for carbamates. For carbamates only we will write atropine. Datura, belladonna, atropines, name of the same poisoning. So whenever there is this kind of poisoning or in the question you have been given some symptoms like there is hypothermia, flushing, dry mouth, mydriasis, tachycardia. So and a patient has consumed, he was walking in the forest or the child was there, he's eaten something from fruit or something. So you can really, in that point you can guess that he or she is talking about the atropine or belladonna poisoning. So when there is atropine poisoning, it's a muscarinic blocker. It's a competitive muscarinic blocker. So what we have discussed, competitive block can be overcome if you increase the levels of what? Agonist. And what is the agonist? Acetylcholine. So we give drugs like physostigmine. Physostigmine is a reversible anticholinesterase. So what it will do? It will increase the levels of acetylcholine. And this acetylcholine will remove the atropine. Simple. Digoxin, we have discussed, it is digibind. Beta blockers. So when there is, you have given beta blockers, so beta receptors are not there. So what to do? You give glucagon. Glucagon, they have separate set of receptors on the heart and they can be used to increase the heart rate. Benzodiazepines, flumazenil. Where do they act? At the GABA A receptor. Morphine, opioid morphine. So what is the antidote? Naloxone, IV naloxone for acute cases, overdose. Methanol, ethylene glycol. So ethylene glycol, there'll be crystals, right? So methanol, ethylene glycol. So you give fomepizole. Ethanol is also an option. So you can see in the question choices if they are given. If both are given, you mark fomepizole. Otherwise, either of this will be given. So you mark that. Tricyclic antidepressant salicylates. Now these have acidic nature and they cause acidosis. So what you do when acidic drug poisoning, you can remove this by making the urine more alkaline, and we can give sodium bicarbonate. Sodium bicarbonate. Paracetamol, it leads to accumulation of the metabolite NAPQI. It can be hepatotoxic. So what you do, you give a drug because why is NAPQI occurring? Because the glutathione stores are not there. So you give N-acetyl cysteine, right? So it replenishes the glutathione stores so that the NAPQI can be metabolized. Then we have heparin. Heparin antidote is protamine sulfate. Protamine sulfate. Warfarin, vitamin K, because warfarin inhibits the synthesis of vitamin K dependent factors. So obviously if there is overdose of warfarin, you have to give vitamin K. Apixaban, rivaroxaban, XA, these are factor XA inhibitors. So again, the antidote also contains XA in them. That is Endixa, net alpha. Dabigatran. So we have idarosizumab. It's a monoclonal antibody. Cyanide poisoning. So we have hydroxycobalamin. Other options we have sodium nitrite plus sodium thiosulfate. Methotrexate, folinic acid, or leucovorin, citroverum factor, same name. Arsenic mercury, heavy metal poisoning, dimer capron. So these are the important antidotes that you should definitely go through. This cannot be missed when you're going for an exam. All right. Now, the best step in the management of septic shock. So shock treatment is also very, very important. So in septic shock, the major problem is there is vasodilatation. So you need drugs to increase the blood pressure. That's the aim in the shocks usually. So we will give something which is a very prominent vasoconstrictor. That is the hint here that we should look for a vasoconstrictor. So which is the best vasoconstrictor out of the lot, or better vasoconstrictor? So one we have dopamine. Now dopamine has effect on dopamine 1, beta 1, alpha 1. Now when you give high dose of dopamine, it will act on the alpha 1 receptors, and yes, it will cause vasoconstriction. But the problem with dopamine is because it also acts on the beta 1, it is slightly more erythemogenic also. Erythemogenic. Vasopressin acts on the vasopressin receptors. Again, it causes vasoconstriction, right? That is an important thing here. Norepinephrine. Now, norepinephrine is a preferred, you can say, a pressor agent. Why? Because it acts on the alpha 1 and it causes vasoconstriction. And like dopamine, it also acts on the beta 1 and it can increase the stroke volume as well. The difference between dopamine and norepinephrine is only this, that this is slightly less erythemogenic. That's the advantage. So we prefer norepinephrine over dopamine. Now vasopressin has no beta 1 action. It is a pure vasoconstrictor only. So out of these, we prefer norepinephrine. It's a vasoconstrictor or pressor agent of choice when we are giving it patients of shock. This kind of shock, septic shock, neurogenic shock, you will see we prefer norepinephrine. Hydrocortisone is a steroid. So it is not the primary first step management. It is an adjunct or adjuvant you can give, but not the primary. Primary, you want to immediately increase the blood pressure and improve the perfusion. That is what is important here. So let's see various types of shock and what drugs should we give, what vasopressors. So anaphylactic shock, very important. Now in the anaphylactic shock, The problem is there is release of histamine and there is laryngeal edema, there is bronchoconstriction, there is vasodilatation. So we give a physiological antagonist of histamine in this case, and that is epinephrine. Epinephrine is given in the dose of 1:1000 by IM rule. This is the drug of choice. Now here it will act on the alpha-1 receptor also to cause vasoconstriction. It acts on the beta-2 to cause bronchodilation. So this is a physiological antagonist of histamine. Septic shock we just now discussed. Norepinephrine, the most important role is that it is a very, very good pressor agent by its actions. Cardiogenic shock, wherever you see oliguria. Oliguria means that is, renal failure is going to happen. So cardiogenic shock with oliguria, always remember dopamine. Because of the action on DOPA1, it will increase the renal flow, right? And it will help in the patients of oliguria. So in this, because it's a cardiogenic shock, with this, we give a moderate dose of 2 to 10 micrograms per kg per minute. Then we have other types of cardiogenic shock. Now there is cardiogenic shock with hypotension and without hypotension. If there is hypotension as a prominent feature, then you should give norepinephrine. If there is only cardiogenic shock, nothing, then no hypotension, all, then you can give even dobutamine, right? Because it is acting on the beta-1 receptors and it will increase the force of contraction and help in this patient. Neurogenic shock. So in this case, you will see a question, patient has a road traffic accident and there is injury to the spinal cord. So mostly it is that kind. And when this happens, the patient will have bradycardia. Normally other shocks have tachycardia because when there is drop in the blood pressure, there is reflex tachycardia. But here, because when the spinal cord is injured, the sympathetic system, that is no longer present there, no? So there is unopposed parasympathetic action leading to bradycardia. So it will be a classical case of road traffic accident with bradycardia. Think of neurogenic shock. Again, the drug of choice for neurogenic shock is norepinephrine. Hypovolemic shock, the first thing that you do is you give a lot of IV fluids. And then you can give later on norepinephrine. So these are the important drugs. What are the important managements of drug of shock? All right. Next question is, a patient with chronic gout presents with recurrent episodes of arthritis. So it's a chronic gout case. Recurrent episodes are occurring. And the patient was initiated on a therapy that acts on step 1. So I marked the step 1. After starting the treatment, the patient showed significant symptomatic improvement. Which drug was most likely prescribed? Now here we have probenecid, colchicine, diclofenac, allopurinol. So you see here, there is the target site 1, whereas xanthine oxidase is written. So there is a drug which is inhibiting. Another area you see here, number 2, I'll write, this is a uricase enzyme. And number 3, I see the excretion by the kidneys is prevented. So for this, you should first know which drugs are given for management of gout and how they act. Then only you can answer this question. Mechanisms are very, very important currently. So whenever there is increase in the uric acid levels, we have 3 major ways by which you can treat such a patient. Number 1, number 2, and number 3. See, either there is acute attack. So whenever there is acute attack, remember, for acute attack, we have NSAIDs, we have colchicine, and if it doesn't work, then we have steroids. So for acute attack only we take this, but this will not actually take care of the prevention. That is only for the acute inflammation we have to decrease. To prevent any future further attacks, because what is the question asking us? The patient showed significant improvement initiated on therapy because there were recurrent episodes of gouty arthritis occurring. So we wanted to give a drug which prevents these recurrent episodes. So you have to give it for a long-term use. You're not giving this drug to immediately stop an acute attack. So for Prophylaxis, we have drugs which either you decrease the synthesis of uric acid, either you increase the excretion of uric acid, or either you increase the metabolism of uric acid. That's the only way by which can work. To decrease synthesis, the enzyme which we target is xanthine oxidase, because this is responsible for synthesis of uric acid. So xanthine oxidase inhibitors, we have a drug called as allopurinol and febuxostat. Drugs which increase the secretion, also called as uricosurics. We have very important probenecid, sulfenpyrazone, and benzbromarone. Increase in the metabolism. So what you do, we give recombinant uricase enzyme, because uricase is the enzyme which converts uric acid into allantoin. This is a more water soluble, and this can be easily excreted. Uric acid can't be easily excreted. It's not very water soluble. So too, we have recombinant uricase enzymes. So we have RAS buricase and pegloticase. Case they have. So our question is the first step which is inhibited. So xanthine oxidase inhibitor. So let's see which of them is a xanthine oxidase inhibitor. Probenecid, no, it's a uricosuric. Colchicine, it is used in acute gout. Diclofenac, it's a NSAID, again used in acute gout. So the option is allopurinol. Right? Okay. So another important question which we should know from this is, which drugs can increase the uric acid levels? Remember, we can use NSAIDs for management of the acute attack. But which NSAID cannot be used? We cannot use aspirin, because aspirin in low dose can increase the uric acid levels. Then we have diuretics, loop diuretics, thiazides. They also increase the uric acid level in the body. Then pyrazinamide, which is an antitubercular drug. Pyrazinamide. Niacin, which is used in patients with a hypolipidemic drug. Right? So these drugs, cyclosporine. So all these drugs, they increase the uric acid level, so they should not be used in the patient of gout. All right. Next question is, a male patient with chronic obstructive pulmonary disease, COPD, was prescribed theophylline. He later noticed a significant increase in the urine output. So it's an adverse effect which is happening. Which of the following receptors mediate this effect of the drug? So basically they're asking you, theophylline causes this adverse effect by acting on which receptors? Now, is it interleukin 10, histone deacetylase, adenosine 1, or beta 2 receptors? So first we will again discuss about theophylline, and then we'll move on to the question and see the answer. Now, theophylline, please remember, it has mechanism of actions multiple. So first mechanism is it causes the phosphodiesterase inhibition. And because of this, it can lead to bronchodilation and anti-inflammatory effects. The second action is because of the enhanced histone deacetylation, also has an anti-inflammatory effect. The third action is because of the antagonist effect on the adenosine. Now, adenosine causes bronchoconstriction. So if you give an adenosine receptor antagonist, it will prevent bronchoconstriction, therefore lead to bronchodilation. So this is the mechanism of action. Now we'll see the adverse effects, which we have to know actually for theophylline. Now, theophylline can cause adverse effects by either inhibiting phosphodiesterase, adenosine, or both. So remember, for phosphodiesterase inhibition, it can cause, remember, P and D. P is pate, D is the mark. So pate means GIT. So it can cause GIT side effects like nausea, vomiting. The mark means head. It can cause headache. Okay. A1. A1, it means that bada fast. A1 chalta hai, fast. So it can lead to diarrhea. Your gut is very fast. Diarrhea. Brain is working very fast. Can cause seizures. Right? So formula 1, A1, very fast. So remember, diarrhea and seizures. And both of them, they can cause arrhythmia. Okay? So our question was for diarrhea, right? Urine output, diuresis. So which of the drug here can cause this? So diarrhea, also here, diuresis. Also for this. Okay? So now the question is, which of the drug can lead to this problem? Interleukin 10? No. It is an anti-inflammatory. Okay? And it is not involved in the case of theophylline. There is no role of interleukin 10 with the mechanism of this. Histone deacetylase, yes, theophylline acts on this, but it has the anti-inflammatory. Adenosine A1, yes. This is the correct option. Beta receptors, theophylline does not act on the beta receptors. So beta 2 agonist will act here, not theophylline. It has again not fit to theophylline. So the correct answer is adenosine 1. Now, what else is important for theophylline is, because this is a drug which is again very important for examination. So it has a very narrow therapeutic index. Okay, so 5 to 20 microgram per ml. If you go above this, so all the adverse effects, signs and symptoms, they will start appearing. Toxicity, signs and symptoms starts appearing. Also, this drug follows zero order kinetics, and it is metabolized by cytochrome CYP1A2. So therefore, there can be a lot of drug interactions with enzyme inducers and inhibitors. So if you give it in a smoker, they will have less effect of theophylline. If you give it with a drug which is an enzyme inhibitor, for example, macrolides like, let's say, erythromycin, it will inhibit the metabolism of theophylline. It will increase the toxicity with this drug. So there can be questions asked on the drug interactions as well. It is used in asthma, COPD, and apnea of prematurity. Remember, for COPD, the best drug actually we have, which are the anticholinergics, because they have a COPD has a prominent cholinergic tone there. So anticholinergics are the best preferred drugs here. Okay. Now, next we have, which of the following drugs acts on both ACE, angiotensin converting enzyme, and NEP, neutral endopeptidase pathways as indicated by the arrows? These are the arrows, thereby influencing both vasoconstriction and natriuresis. Again, a question on the mechanism of action. So out of these four options, which is a drug which has an effect on both the ACE and NEP? Sacubitril, omapatrilat, losartan, and nesiritide. So first, let's see what is sacubitril. It is a neutral endopeptidase inhibitor only. It has no effect on the ACE. Omapatrilat. Omapatrilat is a drug which inhibits both neutral endopeptidase as well as the ACE. So this is our answer. Losartan is a AT1 receptor blocker, angiotensin receptor blocker. Nesiritide is a recombinant BNP. So that out of this, the correct answer is omapatrilat. Now, this was asked in the previous exams. So remember, whenever there is a drug which causes ACE inhibition, what is it basically doing? It is decreasing the formation of angiotensin 2. and therefore there will be decrease in the vasoconstriction. There will be decrease in the aldosterone levels as well. But ACE also leads to metabolism of bradykinin. So this will also increase the level of bradykinin, which is responsible for the cough. Many patients complain when they are on the ACE inhibitors. Then NEP inhibition, you see here, NEP is an enzyme which is inhibiting the, leading to the metabolism of natriuretic peptides. So what are the natriuretic peptides doing actually? They are responsible for vasodilatation and natriuresis. So when you give NEP, they metabolize these BNP into inactive peptides. So in certain diseases where we want to increase the levels of BNP in the body, we can give neprilysin inhibitor, because then what they do, if you inhibit this neprilysin, it will increase the levels of these BNPs and ANPs, and it will lead to vasodilatation and it will lead to natriuresis. This is especially important in patients of heart failures. Okay, but again, bradykinin is also metabolized by the NEP. So if you, any drug which will inhibit this NEP also leads to increase in the bradykinin levels. Now, bradykinin is not only responsible for cough, increase in the bradykinin levels can lead to dangerous angioedema as well. So this drug, omapatrilat, it causes inhibition of both ACE and NEP, and therefore it had a tendency to cause dangerous angioedema. Therefore, it is no longer clinically used, not clinically used, omapatrilat, because of this problem. Now, what other things you should know is a very, very important drug in the heart failure we talk about is ARNI, ARNI, which is a combination of a angiotensin receptor blocker and a neprilysin inhibitor. So what we use here is combination of valsartan plus sacubitril. So because valsartan is a AT1 receptor blocker, it will not allow the angiotensin to act on the receptor, so there will be decrease in the vasoconstriction, decrease in the aldosterone levels. So this can decrease in the afterload, and this decreases the ventricular remodeling, which is because of the aldosterone increase. Sacubitril is a NEP inhibitor, so it will lead to vasodilatation and it will lead to natriuresis. Now this leads to increase in the bradykinins as well, while there is no increase in the bradykinin. Because of these beneficial effects, this drug decreases the mortality in the CF patients. So one of the drug, remember, this drug can never be combined with the ACE inhibitor. Otherwise, it will be doing the same problem which omapatrilat did, right? So angioedema. So therefore, if you are switching a patient from ACE inhibitor to ARNI, there needs to be a washout period of at least 36 hours, because if you give them together, there can be this problem. Okay, next question. A 30-year-old woman presents with PSVT, paroxysmal supraventricular tachycardia. Which of the following will be appropriate for the long-term prophylaxis? Again, it is asking for the long-term prophylaxis of PSVT, paroxysmal supraventricular tachycardia. Now, let's see whether it is IV adenosine, IV esmolol, oral phenytoin, or oral verapamil. Now, PSVT. Two ways of managing. If there is an acute episode, you have to manage it acutely, so acute attack, and for prophylaxis. Obviously, when you are managing an acute attack of PSVT, you have to give the drug by the IV route. But obviously, when you're giving for prophylaxis, you can't be giving by the IV route. So you have to give the drug, the best suited is by the oral route. So the first hint that we get from this is that जो भी IV options we can immediately rule out, because for prophylaxis we can't give the drug by the IV route. So now we're left with oral phenytoin and oral verapamil. So let's continue this further. For acute attack to take care of the PSVT, the drug of choice for us is adenosine. Adenosine. This adenosine has a very, very short half-life of about 10 seconds. So it is given by IV push, IV bolus, 0.1 milligram per kg IV bolus. So it will immediately act and it will take care of the PSVT. So its mechanism of action is number one, it stimulates the ATP sensitive potassium channels. You know, when potassium channel opens, they will move out and there is going to be hyperpolarization. So whenever a membrane is hyperpolarized, it will be inhibited. So it will decrease the overfiring in case of this AV node. The second mechanism is that it will also decrease the calcium current in the AV node. Because what we want to do in PSVT, we want to decrease the impulses conduction from the atria to the ventricle. We want to slow down the AV conduction, right? So because from the atria to the ventricle, we want to slow down the conduction through the AV node. So any drug which is going to slow down the conduction, that should be the drug of choice for us. So here, because it acts immediately, adenosine, it is going to be the drug of choice for here. But what happens, the problem is adenosine is a bronchoconstrictor. So the other options available for us are, you can also give IV verapamil. So if it's not available, we can give IV verapamil or diltiazem. Other option is IV esmolol. But if the patient, they say it's an asthma patient, then you straight away go for a calcium channel blocker. Moving on to the prophylaxis. So in the prophylaxis, because you have to give the drug by the oral route, so we give oral verapamil. You can give oral diltiazem, or we can give oral propranolol. Okay, so these are the preferred drugs. But propranolol, it is contraindicated in asthma. So always see if there is a concomitant condition being mentioned. So if you see here, phenytoin, verapamil, phenytoin is actually a class 1B antiarrhythmic. It has no role in PSVT. Verapamil is a CCB, which is a class 4 antiarrhythmic, and it blocks the L-type calcium channels. So this is the correct answer, that it can be used to decrease, or it can be used to for prophylaxis of PSVT. That is all important to remember. Verapamil, remember one important side effect, which is constipation. Remember this, because it's a calcium channel blocker. So it will relax the muscle, so it can cause constipation. Remember this. So asthma, definitely never use adenosine or never use this drug, which is beta blocker. Okay. Next question is, a patient with a history of acute coronary syndrome has the following lipid profile. Serum low density lipoprotein is 127 grams per deciliter. HDL is 32 and serum triglycerides are 278. Which drug is appropriate for managing this condition? Now this patient, you can see there is a history of acute coronary syndrome, right? So that rings a bell. Any patient of acute coronary syndrome, regardless of whatever the levels are, they are candidates for high statin therapy. Okay. Now, LDL is 127. Normally, it should be less than 100. HDL is also low because normally in males it should be more than 40, females it should be more than 50. Serum triglycerides, normal should be less than 150. So they are elevated and there is a problem, but the main problem here is acute coronary syndrome. The patient is, they are candidates for high statin therapy. Remember that. Now, high intensity statins. High intensity statins. So which are the high intensity statins that we should know? There are two high intensity statins. One is atorvastatin, one is rosuvastatin. But how much dose do we call it as high intensity statin? So remember this rule here, right? 20, 40, 80. 20 to 40 milligram is the high intensity dose for rosuvastatin. 40 to 80 is the high intensity dose for atorvastatin. So just see if there is a high intensity statin mentioned here. Fenofibrate, it is not a statin. It is going to activate PPAR alpha receptors and it's going to decrease the triglycerides. Nothing to do with the LDL levels, or it can't protect the patient here. Rosuva plus fenofibrate. Yes, it's a good option, but first we should always go with the high intensity statin because it will not only take care of the LDL levels, but statins also, they decrease triglycerides to a certain level. If it is still not controlled, then you add on the fibrates, but not the first time only. First, you give single high intensity statin. Rosuva 10 milligrams. Now, this 10 milligrams is less than 20. So, this is a moderate intensity, not a high intensity. Atorva 80, this is the high intensity statin. So, this is the correct answer for this. Now, moving on to what is atorvastatin. It's a high 80 milligram high intensity statin, and it's the first line therapy for secondary prevention in case of acute coronary syndrome or in the patients who have atherosclerotic cardiovascular disease, irrespective of whatever the levels of LDL now they are. Now, so this is recommended for patients who have acute coronary syndrome and let's say there is no history, elevated levels of more than equal to 190, even if there is no atherosclerotic cardiovascular, still we will start with high intensity statin. All right. Then the other is in patients who are diabetics. So in diabetics aged 40 to 75 years of age, and the LDL levels are greater than equal to 70, and they have multiple risk factors. So there also you will give high intensity statin. So these are the conditions where you give high intensity statins: atorva, rosuva. So I told you the dose: atorvastatin 40 to 80, rosuva 20 to 40. Statins, very, very important drugs because they are competitive inhibitors of the HMG-CoA reductase. So what is the role of HMG-CoA reductase? So you know that de novo synthesis of the cholesterol takes place in the liver. And what are the steps involved? So first is citrate converts to acetyl-CoA, which converts to HMG-CoA, and this will convert into cholesterol. The enzyme responsible, the first step is ATP citrate lyase, and the second step from the HMG-CoA to cholesterol, we have HMG-CoA reductase. So statins are going to target this step. Now, there was a question recent asked, which is the drug which is targeting the first step, which is a competitive inhibitor of the ATP citrate lyase. So here the drug which we have is bempedoic acid. Okay, so statins, they lead to, after they cholesterol levels, so they lead to decrease in the levels of the cholesterol. Now, what will happen when they decrease the cholesterol levels. On the liver, we have receptors which are called as LDL receptors. And what is the role of this LDL receptors? To pick up LDL from the blood, so that there is decrease in the LDL level in the blood. So when the cholesterol is not synthesized because of the statins, the LDL receptors, they get upregulated. They will try to take up more LDL from the blood. So they will take up more LDL from the blood, ultimately decreasing the level of LDL in the blood. That is the important thing, or the major important role of statins and how they work. Now, if we see this particular receptor, LDL receptors. Now, these receptors, they get metabolized by PCSK9. It leads to degradation of these receptors. So it will destroy these receptors. But if we give an inhibitor of this PCSK9, then LDL receptors will be there for a longer period of time and more LDL can be taken up. So therefore, we have PCSK9 inhibitors. So these are also very important drugs which are asked common. One we have inclisiran and the other is evolocumab. So these are the PCSK9 inhibitors. They are given in addition. If the statins and alone are not enough, then we add on these drugs to decrease the LDL levels. Now for statins, these drugs, the major problem or the adverse effect is myopathy. These are contraindicated in pregnancy and in children less than 10 years. Pravastatin is a drug which can be given in children less than 8 years. Okay? I mean, it should not be given in less than 8 years. That is the rule. So it can be given in less than 10, but cannot be given less than 8. That is the important thing here. And this is also safe in liver disease. Pravastatin is safe in liver disease. Okay. Next question is, which of the following drugs requires coagulation profile monitoring? Right? So whether it is lepirudin, enoxaparin, fondaparinux or dabigatran. Now lepirudin is a direct thrombin inhibitor which is parenteral. Enoxaparin is a low molecular weight heparin. Then the fondaparinux inhibits the factor 10A and dabigatran is a direct thrombin inhibitor, but it is given by the oral route. Now out of this, lepirudin, which is given by the parenteral route acting on as a direct thrombin inhibitor, it doesn't have a very stable pharmacokinetics, or it has a variable pharmacokinetics. Because of this, it needs monitoring. Now, other drugs, enoxaparin, fondaparinux and all, they do not require that kind of monitoring. So, enoxaparin is a low molecular heparin and it has more activity against factor 10A as compared to heparin, the unfractionated heparin, which acts on or inhibits factor 10A as well as factor 2A. This will require monitoring, but not enoxaparin. Fondaparinux only inhibiting factor 10A, very minimal effect on thrombin, again does not require monitoring. Dabigatran, remember, it's an oral drug and it has a very fixed dose regime and it has a very, very predictable pharmacokinetics. It also does not require any kind of dose monitoring. So dabigatran is used to prevent stroke in patients who have AFib, atrial fibrillation, or in DVT. That's the role of dabigatran. Now, these are the few drugs and which drugs require monitoring, which does not, we can do from this particular table. So, heparin requires monitoring. Yes, heparin definitely requires monitoring. Low glycemic heparin, as I said, it does not require monitoring in routine. In pregnancy, or if there is some renal disease, then it might require monitoring. In routine, it does not require monitoring. Okay. Fondaparinux does not. Factor 10A inhibitors, again, do not. Warfarin, yes, it requires monitoring. That is the INR. Direct thrombin inhibitors, parenteral. Yes, like we did right now, it requires, like ergatroban, which is important here, requires monitoring. So APTT. And direct thrombin inhibitors, which is oral dabigatran, again, does not require monitoring. Now, some important points on warfarin. Warfarin is a very, very important drug for the examination point of view. Now, warfarin, it inhibits the vitamin K epoxide reductase. So, therefore, it inhibits the synthesis of vitamin K dependent factors like factor 2, 7, 9, 10, also protein C and S. But it has a lag period of about 5 to 7 days because the already formed clotting factors, it cannot do anything about that. Only it inhibits the synthesis of the newer factors, right? Okay, what are the major adverse effects? The first one and the most common is bleeding, right? So we can treat the bleeding. So it depends, like if it's a minor bleed and the INR is less than 10, you should stop the drug and you can give vitamin K. But if the INR is more than 10 and there's a major bleed, then definitely you have to stop the drug and you cannot restart warfarin as immediately. So what is the other thing that you can do? You can give a 4-factor prothrombin complex. If that is not available, then you can give fresh frozen plasma. The second one we have cutaneous gangrene, and the third is the purple toe syndrome, can be purple foot syndrome or toe syndrome. So cutaneous gangrene, the reason we should know, it is because of microvascular thrombosis. The gangrene is because cutaneous hai, so microvascular thrombosis. Purple toe syndrome is because of cholesterol embolization. Remember the difference. That is microvascular thrombosis. This is cholesterol embolization. Next question. It was a recent question which was asked. Match the following anti-aging drugs with their mechanisms. Spermidine, metformin, resveratrol, and rapamycin. So spermidine is actually EP300, histone acetyltransferase inhibitor. Metformin, we all know it's an anti-diabetic drug, acts on the AMPK, it activates AMPK and decreases the gluconeogenesis, and it's a drug of choice for type 2 diabetes mellitus. Then resveratrol is a drug which acts on the SIRT1 activator, and rapamycin is an mTOR blocker. So this is the correct answer here. So these drugs, because they are newer drugs, so you might as well know one line about each of these drugs. So spermidine, which is activating the autophagy and enhanced clearance. So all these are anti-aging drugs which have been used. Even this is also these days has a, and it's used as an anti-aging drug as well. So resveratrol, rapamycin. So you can remember these drugs. Next one. A cancer patient undergoing chemotherapy was administered an anti-emetic drug. So there's a cancer patient, chemotherapy and anti-emetic drug was given to them. Shortly after that, the patient developed symptoms like acute dystonia, bradykinesia, and tremors. Which of the following drugs is most likely responsible for these symptoms? So see whether it's ondansetron, metoclopramide, meclizine, or scopolamine. So what are the things given to us? It's a anti-cancer, it's a cancer-induced chemotherapy-induced vomiting, and so they were given antiemetics. So this antiemetics has caused some central nervous system side effects, which is acute dystonia, bradykinesia, tremors. So this is actually, what is it? It is nothing but it is extrapyramidal syndrome or symptoms which occur and this occurs when there is blockage of D2 receptors in the central nervous system, the nigrostriatal pathway. So which of these drugs crosses the blood-brain barrier and blocks the D2 receptors in the nigrostriatal pathway? Let's see. The first option is ondansetron. What does ondansetron do? Ondansetron is a 5-HT3 antagonist. It is a drug of choice for chemotherapy-induced nausea, vomiting, for post-operative nausea, vomiting, for radiotherapy-induced nausea, vomiting, but it does not have any effect on the D2 receptors. So this is not the answer. Metoclopramide has an effect on the D2 receptors, actually on the CTZ, and therefore it is a antiemetic. It also acts on the 5-HT4 receptors in the GIT, and it's a prokinetic. Now, what this drug has problem is that it can cross the blood-brain barrier, and it can also block the D2 receptors in the brain and therefore the EPS. So therefore, this is the answer. What about the other two? Meclizine. Now, meclizine, actually, it is an antihistaminic drug. This is used for seasickness. Okay. While scopolamine, we have just done before that this is a drug which is also available as a patch, or the other name is hyoscine. This is used for motion sickness. Okay, not the chemotherapy-induced vomiting. So the correct answer for us out of this is metoclopramide, which is a drug which crosses the blood-brain barrier, and this. Now, remember metoclopramide versus another drug which is domperidone. Domperidone also acts on this particular, it's the same receptor. The only difference from metoclopramide is that it does not cross the blood-brain barrier. Therefore, there will be no extrapyramidal syndrome. So, if there is in patients of Parkinson's, there is vomiting or nausea, we prefer to give domperidone because it has no effect on the D2 receptors on the brain, because it will further aggravate Parkinsonism signs and symptoms. So, remember this metoclopramide, this is a cause of drug-induced Parkinsonism. And for drug-induced Parkinsonism, the drug of choice are your centrally acting anticholinergics. Because in the brain, the balance is lost between dopamine and acetylcholine. So when D2 receptors are blocked, so dopamine cannot go and act on the D2 receptors. The only other neurotransmitter we need to target is the acetylcholine. All right. Similar question, the next one. Which drug can be given to treat the below condition in a patient on treatment for schizophrenia? So what is this condition? There is a spasm of the neck muscles, you can see, and even the eye muscles. So there is spasm. So the patient was a schizophrenic patient. The hint is that there was some drug given for schizophrenia which led to this kind of problem. So we know in schizophrenia, we give typical or we give atypical antipsychotics. Now, typical antipsychotics, they basically are going to block the D2 receptors. And I've already discussed whenever D2 receptors, they are blocked, especially because they're not very selective for the area to treat schizophrenia. They can also go and block the receptors in the nigrostriatal pathway as well. So when they block the nigrostriatal pathway, so a lot of extrapyramidal symptoms, they will appear. So this is a example of a extrapyramidal syndrome, which is caused as acute dystonia. Now, atypical antipsychotics, because they are free of they don't have much effect on the D2 blockers, they mostly act on the 5-HT receptor. So they have less tendency to cause this. So the options are no treatment required, benzhexol, haloperidol, or diazepam. So no treatment cannot be, you have to treat the patient. Benzhexol is a centrally acting anticholinergic. anticholinergic. I was just talking to you, if there is a drug-induced Parkinsonism or such kind of EPS, you have to take care of the other end, which is dopamine, because normally dopamine, acetylcholine, they are balanced. So when there is a drop in dopamine or there is blockage of this dopamine, then the acetylcholine becomes relatively more predominant. So these actions are because of this. So you have to then give a centrally acting anticholinergic. So this would be the answer. More haloperidol. What is haloperidol? It is a typical antipsychotic, and probably this is a drug which is causing it. So if you give more of haloperidol, it will further aggravate the condition. Diazepam, it has no role in this kind of spasm. It is a centrally acting muscle relaxant. Centrally acting muscle relaxant, but it acts at the level of the spinal cord, not too high on the the nigrostriatal pathway. So it is not a select or the drug of choice here for this. So again, this very, very important table of what are the side effects or the adverse effects or the extrapyramidal symptoms which is seen the typical antipsychotics. So the mnemonic for this is ADAPT, A-D-A-P-T, in order of how they occur. Acute dystonia is the earliest. AD is acute dystonia, akathisia, Parkinsonism, and T is tardive dyskinesia. So acute dystonia, just to show this patient, if you see, this is what is acute dystonia. So what is the drug of choice here? We have centrally acting anticholinergic like benzhexol. That is a drug of choice. Let's say this is not available. We have a better available drugs which are most often or more common seen in the hospital settings. We have antihistamines like promethazine, which also has an anticholinergic activity. So antihistamine with an anticholinergic activity can also be used. It can cross the blood-brain barrier. So this is another option. Rather, this is more easily available. Akathisia. It is most common, and the patient has an irresistible desire to move around, can't stand still. So here the anxiety is main in the patient. So you have to bring down the anxiety. So for anti-anxiety drug we have is propranolol. So the first line drug here is propranolol. Parkinsonism, again the same thing, benzhexol or promethazine. Tardive dyskinesia. Now, tardive dyskinesia is the last to occur. And in this, the problem is not dopamine receptor block. The problem here is because it occurs very late, even after sometimes you stop the therapy. Here, there is increase in the dopamine is a problem. Remember, increased dopamine is a problem. So, what to do? So, this is the neuron and this is the dopaminergic vesicle. Now, dopamine should be stored in the vesicle and then it can be released. If it is not stored in the vesicle, if it goes outside, it gets metabolized. So dopamine has to get into the vesicle to be released. Now here the problem is increased dopamine. Now you want to decrease the dopamine. So we want to stop it from entering into the vesicle. Now what is helping it to get into the vesicle? Now there is a specific transporter here which helps dopamine to get into the vesicle, and this transporter is VMAT. 2 transporter, vesicular monoamine transporter. So if we can block this transporter, we will not allow the dopamine to get into the vesicle and therefore it won't be released. So we have drugs here, VMAT2 inhibitors like tetrabenazine, tetrabenazine, valbenazine. So benazines. Now, malignant neuroleptic syndrome doesn't follow any hierarchy. It can occur anytime with any dose, and it is the most fatal out of them. So whenever this occurs, you have to immediately stop the drug. And the drug of choice here is dantrolene. You can give bromocriptine as well, but the drug of choice is dantrolene. So these are the management of extrapyramidal symptoms. Now, just one of 2 lines about the atypical drugs which are equally important. Atypical drugs. Most important is clozapine. It is a drug of choice for resistant schizophrenia. Not given routinely because it has a lot of side effects. So major adverse effects rather, it has seizures, agranulocytosis. This is not dose dependent. So remember, agranulocytosis is something which is not dose dependent. So it can happen with any of the dose. So it is not dose dependent. Seizures are mostly dose dependent side effects, so they can occur with this as well. Then we have metabolic syndrome. So this is metabolic syndrome. Then we have increase in salivation called as sialoria or wet pillow syndrome and myocarditis. Remember these adverse effects. Another drug we have is olanzapine. It also has a maximum tendency to cause metabolic syndrome. Then we have risperidone. Maximum risk. Risk means risk. Maximum risk of D2 block, therefore EPS. Aripiprazole. It is a partial agonist at the D2 receptors. Therefore, there is least tendency to cause EPS. Then we have pimavanserin. This has no D2 action. Therefore, used in Parkinsonism induced psychosis. And then we have ziprasidone. Zip like. So this is Torsades de Pointes. It can cause QT prolongation. All right. Next we have, which of the following drugs acts on the sodium channels and enhances slow sodium inactivation? So only don't read sodium inactivation, read slow sodium, specifically slow. So it has a role here. Phenytoin, lamotrigine, lacosamide, topiramate. So we see the various antiepileptics here and then come back to this answer. Phenytoin, it acts on the fast sodium channels. So it inactivates the fast channels, not the slow. And important thing, another is that this is a drug which can lead to fetal Hydantoin syndrome. And there can be gingival hyperplasia, hirsutism, etc., which can occur with this drug. All right. Now, valproate, very, very important. It's a broad spectrum drug. Again, it inhibits the sodium channels, but again, this is on the fast sodium channels, not the slow sodium channels. A lot of times, the side effects, adverse effects are asked for valproate. So, it can cause vomiting. It can cause alopecia. It can cause neural tube defects, spina bifida. It is the most teratogenic drug that we know, okay? Then there can be weight gain. It can cause increase in the ammonia. So it is hepatotoxic as well. Lacosamide, it is a drug which shows slow sodium inactivation. Topiramate, very important drug. It's a broad spectrum drug, acts on the sodium channels, on the AMPA receptors also. Again, fast sodium channels. And on the AMPA receptor, inhibits the AMPA receptors, right? So the important thing about topiramate is it can cause weight loss, therefore used in obesity. Then it can cause renal stones as well. Then carbamazepine, again it follows or it prolongs the fast sodium inactivation. Remember, it can lead to agranulocytosis. It can lead to syndrome of inappropriate ADH secretion. Therefore, it can cause decrease in the sodium. It is caused as dilutional hyponatremia. Very, very important drawback with this. Now, we have a drug oxcarbazepine. It has less adverse effects, but the adverse effect which is more as compared to carbamazepine is hyponatremia. Also remember, this is a auto-inducer, induces its own metabolism. Lamotrigine also blocks fast channels, so this drug is safest in pregnancy. Safe in pregnancy along with levetiracetam. Vigabatrin inhibits GABA transaminase. GABA transaminase. Adverse effect which is important for this is V for vigabatrin, and it can cause visual field defects. Some are important things that you should know about antiepileptics. So the question was, which of the drug enhances the slow sodium inactivation? So we did lacosamide. Cosa, dire dire, slowly, it blocks this. So it prolongs or it makes it more stable. All right. Now, which of the following is a novel useful drug in depression? So new antidepressant: escitalopram, trazodone, vilazodone, clonazepam. Now let's see. Escitalopram is a drug which is an SSRI. But this is not a new drug. It is a not new, old drug. Trazodone is also an old drug, which is an atypical drug. And it is not used also currently because the major problem with this is priapism. Vilazodone is called as PARI, which is serotonin partial agonist and reuptake inhibitor. Clonazepam is a atypical antipsychotic. So the correct answer here is, for us, it is vilazodone. Now we know that in depression, the preferred group is SSRIs, right? So SSRIs, they are the preferred drugs. We have TCAs also, but they are not the preferred group of drugs. SSRIs are comparatively preferred. Then we have SNRIs as well. So TCAs have a lot of adverse effects because what they do, they block lots of other, apart from inhibiting the norepinephrine transport as well as the serotonin, it also have an effect on the muscarinic. So it blocks the muscarinic receptors, they block the alpha-1 receptors, they block the histaminic receptors. So they have anticholinergic side effects, they have postural hypotension, they have antihistaminic problems as well. So therefore, we prefer SSRIs, which only block the reuptake of serotonin, and they are the preferred drug of choice. The problems they can cause is diarrhea, GIT, nausea. But the most often asked side effect is sexual dysfunction. And its drug interaction with other drugs which can increase the serotonin levels, like TCAs, like MAO inhibitors, like an antibiotic, linezolid. So all of them, they increase the serotonin levels, should not be combined because this can lead to serotonin syndrome, and which is increased level of serotonin in the body. And the drug of choice to take care of this, you already, what you do, you give a 5-HT blocker. So we have cyproheptadine. Then SNRIs, they are preferred because they only target they are just like TCAs, but they have no effect on the other receptors. Then the new ones that you should know, one we have done is vilazodone. Other name is vortioxetine, which is also called as MASA, which is multiple serotonin agonist, antagonist. Then we have S-ketamine. It was a recent exam question. S-ketamine, which blocks the NMDA receptors available as nasal spray for resistant depression. Then we have brexanolone, which is GABA modulator, and this is given for postpartum depression. Okay. All right. So moving on to the next question. A hypertensive patient with chronic kidney disease and frequent episodes of renal colic is being evaluated for diuretic therapy. So let's highlight the things. Hypertensive patient has a chronic kidney disease and there are frequent episodes of renal colic, is being evaluated for a diuretic therapy. So you want to start diuretics in them. Which of the following diuretics is most suitable for this condition? Furosemide, mannitol, hydrochlorothiazide, or spironolactone. So what is happening in this patient? There is chronic kidney disease and there is recurrent renal stones. So recurrent renal stones are mostly calcium stones. So there is increased calcium in the urine. So you would like to give a drug which decreases the excretion of calcium in the urine. So that is what you want to give here. So let's see which drug can do that. Furosemide. What is the role of furosemide? It is a loop diuretic. Remember, loop loses calcium. So it will increase the calcium in the urine and it will enhance the formation of calcium stones. So definitely we cannot give this drug. Mannitol. Mannitol is osmotic diuretic, right? So it is used where? When there's increase in the intracranial tension, it is used in acute congestive glaucoma. This is dialysis disequilibrium. So it has no role here. So no role in calcium. So not a correct answer. Hydrochlorothiazide. This is a thiazide. And you know, all the adverse effects of thiazides and loop diuretics are same except for the effect on the calcium. So this drug actually retains calcium in the body. So it will cause less formation of calcium stones. So this should be the correct answer. Spironolactone, it is a potassium sparing diuretic. It is basically given in case of resistant hypertension. So it has no relation when you talk about the calcium levels as such. So hydrochlorothiazides, it acts on the early distal convoluted tubule on the sodium chloride transporter. Okay. Now it is used in case of hypertension. Yes, it in case of wherever there is hypercalciuria, increased calcium in the urine predisposing to kidney stones, edema, and in nephrogenic diabetes insipidus. Adverse effects important. Remember, if you're comparing loop and thiazide, I told you just one difference, otherwise it's the same. So you can remember high GLU and low P, M, and S. Low PMS, high GLU. This means increase in the level of glucose, lipids, and uric acid. Low potassium, magnesium, and sodium. So for loop and for thiazide. So only difference is it will include a C also here. And for loop, the calcium will go here. Rest is all the same. All right. Next is a patient with HIV is newly diagnosed with MDR tuberculosis. Which will be the most appropriate regime? So TB is very, very important topic, often asked in one way or the other. So this is a multi-drug resistant tuberculosis. So what is the current regime for multi-drug tuberculosis that you should know? Whether it is INH plus levofloxacin, pyrazinamide, ethambutol, or it is this one with streptomycin, ethionamide, INH levofloxacin, C, INH clarithromycin, pyrazinamide, ethambutol, and D is the B-PAL-M regime. So currently what we have is the newer B-PAL-M regime that we have to give in MDR tuberculosis. So very, very important, and let's discuss few points about the management of tuberculosis. Now, anti-TB regime. If it is a drug sensitive tuberculosis, so what our guidelines, NTP guidelines against the WHO guidelines. There are two guidelines, but we follow in India the NTP guidelines, and that is you have for 6 months therapy, 2 months HRZE, and 4 months of HRE. Now, WHO now has taken out that 4-month regime, and this is 2 months of HPMZ and 2 months of HPM. So difference if you see here is rifampicin has been replaced with this P. What is this? So rifampicin has been replaced with rifapentin. The other change is that ethambutol has been replaced with moxifloxacin. So ethambutol has been replaced with moxifloxacin. So these are the two changes in the WHO criteria. Moving on to the resistant cases. So rifampicin resistant tuberculosis and the multi-drug resistant tuberculosis, which means there is resistance to rifampicin plus INH. The management is the same. So now we are giving in these cases B-PAL-M regimes. So what is B-PAL-M regime? It is bedaquiline, pretomanid, linezolid, and moxifloxacin. So we give B-PAL-M regime, usually given for 6 months. But the patient needs to be more than 14 years of age, clinically stable. There should be no resistance to fluoroquinolones. So these are certain things, and it should be a pulmonary tuberculosis, not the extrapulmonary ones. So they are the candidates for B-PAL-M regime. Then after that, we have the pre-XDR tuberculosis, where there is MDR plus fluoroquinolone resistance. So here what you do, you simply remove the fluoroquinolone from B-PAL-M. So it becomes only the B-PAL regimes for 6 to 9 months. Then XDR tuberculosis. This is all this plus resistance to either bedaquiline or linezolid. So we have the long oral regime here. So all these 3 drugs basically are group A drugs have become resistant: fluoroquinolone, bedaquiline, linezolid. That is the thing here. Now, the first line drugs of this drug sensitive tuberculosis, we have the peri now. Initially streptomycin was there, but it is not there. So we have PERI. Peri drugs, right? That's how we remember. What are the important things that you should know about these drugs? Pyrazinamide, ethambutol, rifampicin, isoniazid. So all of these drugs are cidal except for ethambutol, and they act on either intracellular or extracellular ways. Only pyrazinamide has maximum intracellular activity. Adverse effect that you should know for pyrazinamide is that it is the drug which is the most hepatotoxic out of the lot. So it has maximum hepatotoxic and it causes increase in the uric acid levels. Ethambutol, E for I, retrobulbar neuritis and red green color blindness. Important. Rifampicin, it is hepatotoxic, yes. Then various syndromes it can cause. Flu-like syndrome, respiratory syndrome. Important thing is it can cause staining of the secretions. Staining of the secretions of the urine, of the lacrimal secretions. Of the patients wearing contact lenses, they will get stained. So that is because of rifampicin. You should tell the patient that it can lead to staining of the secretions. Isoniazid. Isoniazid is I and H, right? So N stands for neuropathy. So it can cause peripheral neuropathy. Important. H stands for hepatotoxicity. So it is it can cause peripheral neuropathy, it can cause hepatotoxicity, and also it can in some patient leads to psychosis. To prevent neuropathy, that's why you have to give pyridoxine with this. Must. Now, action is that pyrazinamide, it has the maximum sterilizing action. Sterilizing action that we should know. Rifampicin, these are best for slow or spurters. And these work best against fast or rapidly multiplying organisms. Used in pregnancy, they can all be used in pregnancy. Isoniazid being the safest. Whether they can be used in liver failure or renal failure, remember ethambutol can be used in liver failure. So all the other drugs, they are hepatotoxic, they can't be used. So they can be used in renal failure. So both these drugs especially, they are safe in renal failures. Now, bedaquiline, very, very important drug. Mechanism is so many times has been asked. It blocks the ATP. Bedaquiline is on the bed, sitting on the bed, is lying, relaxing. So there is less of energy. So it blocks the mitochondrial ATP synthase and therefore decreases or doesn't, the bacteria don't have any energy left, basically. That's the reason. It's a cidal drug with a very long half-life of about 160 days. The major problem with this is it can cause QT prolongation. Delaminate, pretominate, they're also new drugs, but they cause or inhibit the mycolic acid synthesis. Delaminate also can increase the QT level, QT prolongation or increase the interval. Pretominate with the P stands for peripheral neuropathy. Linezolid, it's an antibiotic and it can lead to bone marrow depression and also peripheral neuropathy. Clofazimine, anti-leprotic, but also now is used as an anti-tubercular drug. Now this drug has one major problem, ichthyosis. So fish, very dry, fish-like skin can be seen with clofazimine. Okay, moving on to the next question is, a boy has high-grade fever, severe pain, swelling of the right knee. Synovial fluid shows gram-positive, catalase-positive cocci in clusters. And it is sensitive to oxacillin and cefoxitin, what is a drug of choice. So see here, they have given you the hints to identify the organism. Gram-positive, catalase-positive clusters. So the organism is Staphylococcus aureus. Now, whether this strain is methicillin resistant or methicillin sensitive, if it is sensitive to oxacillin and cefoxitin, so we mean it is a methicillin sensitive Staph aureus. If it was resistant, then it is MRSA. Now, which are the drugs which are, can be used in this case? Vancomycin, cloxacillin, penicillin G, erythromycin. Now, in MSSA, if it is sensitive to oxacillin, what are the other drugs which can use? Because, the Staphylococcus aureus, it's penicillinase producing organism. So, therefore, penicillin G cannot be used against. Erythromycin is a macrolide. Let's see how it works. So, macrolides, they have no action against this organism. Now we are left with vancomycin and cloxacillin. Now, vancomycin, it is a drug of choice for MRSA. So, had it been MRSA, then here the drug of choice is vancomycin. But here it is sensitive to oxalin cefoxitin. So, which are the other drugs, if we see here, which can be used where there is penicillin producing organism? So, remember these drugs. Corn MD, cloxacillin, oxacillin, then we have nafcillin, decloxacillin and methicillin. So already he has told that oxacillin sensitivity. So obviously the other drugs will also be sensitive to it. So we have the option here is cloxacillin. So here the correct answer is cloxacillin. Remember. Now we were talking about MRSA. Let's see. So drug of choice is vancomycin. What happens if there is resistance to now vancomycin also? It is called as VRSA. The drug of choice for VRSA, we have daptomycin. But it can't be given if there is lung involvement or pneumonia. So for pneumonia, we have the drug of choice as linezolid. Why not in pneumonia? Daptomycin, because it gets inactivated in the lungs. So can't be used in cases of lung infections. So that is the rule here. Now, few infections and the drug of choice. Quickly, let's go through that. What are the? So mycoplasma or any kind of atypical pneumonia. Remember, we cannot use beta-lactams here because mycoplasma don't have cell wall and beta-lactams, they work against the cell wall. So they're out of question here. So the drug of choice for mycoplasma pneumonia, atypical pneumonia, we have macrolides like azithromycin. Macrolides. MRSA, I told you right now, we have vancomycin. Also, we can use other drug which can we use now, 5th generation. Only beta-lactam which we can use is 5th generation cephalosporin. It's not the drug of choice, but it can be used. VRSA, not pneumonia. VRSA, I've told you, we have daptomycin. Superbug, colistin. Pseudomonas, the drug of choice is ceftazidime. Enteric fever, ceftriaxone. Anaerobic infections, if it is like this is a diaphragm, above diaphragm and below diaphragm. It is above diaphragm, we have clindamycin. Below diaphragm, metronidazole. Meningococcal infection, we don't know yet the causative organism. So empirical therapy is given with ceftriaxone. So once we know, the definitive is penicillin G. Pseudomembranous enterocolitis, the drug of choice, oral fidaxomicin. Can also use oral vancomycin. Maybe it's not available, then it goes oral vancomycin. Gonorrhea, ceftriaxone. Plague, streptomycin. Next is, a patient from Rajasthan presents with a mixed infection of Plasmodium vivax and Plasmodium falciparum. So it is a mixed infection. On the second day of treatment, what is the correct dosage for managing the infection according to national guidelines? So out of these four options, which we have been given, so best is first we see what is the dose and then we come back to these options. So if it is a vivax malaria, ovale malaria, which is chloroquine sensitive, definitely if it is chloroquine sensitive, you're going to give chloroquine. Chloroquine is given for clinical cure, but we know they have the hypnozoids part also. You have to give the complete or radical cure. You have to give primaquine. Primaquine 15 milligrams for 14 days for the complete radical cure. Or the other option is single dose of tefenoquine. Coming to chloroquine resistant malaria or falciparum malaria. The treatment is, because chloroquine is not working, the drug of choice in India or the treatment of choice is artemisinin combination therapy, ACT. So with artemisinin combination therapy, we have to give primaquine as well, for not for the radical cure or the effect on the hypnozoids. This is actually going to kill the gamete. So it has a gametocidal effect here. So we don't use prolonged period of time, because for falciparum at least, we are not going to use for a prolonged period of time. For vivax, yes, but for falciparum, if it is there, then we do not use it for prolonged, because it has no hypnozoid stage. It has only the role of primaquine here is gametocidal. So vivax, yes, you will give for 14 days, but for falciparum, you will not give it 14 days, only we keep it to single dose. So we see what is the drugs that we give. So we give artesunate, because it is a alone. You can't give artemisinin combination therapy. So we have sulfadoxin and pyrimethamine plus primaquine we are giving. Okay, so artesunate you give for 3 days. This you only give for day 1, and primaquine is given on day 2. Coming to the dose, for this we give 4 tablets of 50 milligrams. So roughly this is 200 milligrams. Sulfadoxin, day 1, we give 2 tablets of this. So this is, the dose is 1500 milligrams of sulfadoxin and 75 milligrams of pyrimethamine. For falciparum malaria, you give 45 milligrams of primaquine on day 2. And how it is given? This is given 6 tablets of 7.5 milligrams. 6 tablets of 7.5 milligram. That's how it becomes 45. So this is on day 2. Okay, day 2. Now this is correct for all the states, but northeastern states, they have developed resistance to sulfadoxin pyrimethamine. So for the northeastern states, remember a mnemonic NEEL, N-E-A-L. So here we give artemether plus lumefantrine. Yes, you have to give primaquine as it is. So the dose is this. Now, if there is a mixed infection, so mixed infection means both vivax and falciparum. So everything is going to be the same as we discussed for falciparum. The only thing here is that primaquine, it needs to be given for 14 days. 15 milligrams. Okay, remember it has to be given for 14 days as 15 milligrams. So here we are not going to give, you can say here, if it is a mixed infections, we are not giving on the second day sulfadoxin. So this is wrong, because on the second day it is only artesunate and primaquine. So this option is wrong, this option. Now out of this, I told you what is right here. we have to give it for a prolonged period of time, that is 14 days, 15 milligrams. So if it's a mixed infections, we will go for this. Severe malaria or cerebral malaria, we give IV artesunate. That is the drug of choice. In pregnancy, so pregnancy we see if it is a vivax infection, if it is a falciparum infection, or there is some complication. So uncomplicated vivax, uncomplicated falciparum, or a complicated malaria. Vivax uncomplicated, the drug of choice is chloroquine. Falciparum's first trimester, we give quinine because ACT can be teratogenic. So second and third trimester, we can give ACT. Complicated, we don't care about the trimester. We have to save the life of the woman here. So we will give IV artesunate. In all these cases, remember, primaquine is contraindicated in pregnancy. We will not give primaquine here, not give here, anywhere, because it leads to hemolysis in G6PD deficient patient. Fetus is G6PD deficient. So in pregnancy, primaquine is contraindicated. All right, moving on to the next question. A patient with a gynecological malignancy started on methotrexate. Later, she develops oral and gastric ulcers. Which nucleic acid synthesis or nucleotide synthesis is affected in her? Simply, they're asking you the mechanism of methotrexate here. You know that methotrexate is a antimetabolite, folate antagonist. Okay, it inhibits the enzyme dihydrofolate reductase, and it will not allow the conversion of dihydrofolic acid to tetrahydrofolic acid. That is a point where it is inhibiting. Also, it inhibits the enzyme thymidylate synthase. This thymidylate synthase is required for conversion of DUMP to DTMP. Deoxyuridine monophosphate to deoxythymidine monophosphate. So basically, we are not allowing the formation of TMP. So the answer is TPM. So mechanism basically is asked. So anti-cancer drug, a brief, what are the important salient features of few anti-cancer drugs? We have first the alkylating agents. So these are the alkylating agents which give an alkyl group to N7 of guanine. What is the important? Cyclophosphamide. It has a very toxic metabolite which is acrolein. It can lead to hemorrhagic cystitis. And to prevent it, we can give a drug which is Mesna. Treatment is with steroids. Busulfan, it leads to pulmonary fibrosis. One of the major problem is with busulfan is pulmonary fibrosis, and the treatment is pirfenidone. Procarbazine, it can lead to disulfiram-like reaction. Cisplatin, it is an alkylating agent and it is one of the most emetogenic and it is nephrotoxic as well. So the two problems are it is very, very emetogenic. A lot of vomiting, nausea. So treatment is with 5-HT3 antagonist for early vomiting. If it is delayed vomiting, then you give a drug which is aprepitant. So the drug is aprepitant. It is nephrotoxic as well. And for this we give amifostine. That is the treatment. L-asparaginase, it can increase the blood glucose levels. Remember, the important point here is it has a bone marrow sparing effect. It has no this drug does not destroy or cause any adverse effect on the bone marrow. Mostly all the anti-cancer drugs affect the bone marrow. There are 3 drugs. One is L-asparaginase, other is vincristine, and the third one is bleomycin. They have bone marrow sparing effect. So bone marrow sparing effect. So vincristine also has the same bone marrow sparing effect. Now vincristine, vinblastine, and vinorelbine, they act on the M phase mitotic spindle inhibitors because they inhibit the microtubule polymerization. Okay, so vincristine, I've told you that the important thing to know about this drug is that there will be bone marrow sparing effect. Other adverse effects here we can see syndrome of inappropriate ADH secretion, and they can also cause nerve palsy. Irinotecan, it is a topoisomerase inhibitor. So the problem is cholinergic. Cholinergic side effect especially it can cause, which is diarrhea. So what you give? You pre-treat with atropine, anticholinergic. So usually this occurs if it's an early episode, then it is mostly cholinergic. Later on it occurs, then there can be damage to the intestinal mucosa, then you can give clopramide also. Doxorubicin, daunorubicin, epirubicin, so all have rubies in them. So ruby is red. So red is the color of the heart. So they are all cardiotoxic drugs. And the treatment here is the iron chelator, dexrazoxane. Then methotrexate we just now did. What is the important thing to know about this drug? This methotrexate can cause bone marrow depression and it is hepatotoxic as well. And what is the antidote for the overdose? So treatment is folinic acid. Folinic, not folic acid, but folinic acid, also known as leucovorin, also known as cetrovorin factor. Then 5-fluorouracil, it was asked what is the major drawback or side effect, adverse effect with this is hand and foot syndrome. Another one here I want to add is bleomycin. So bleomycin, the important, it is a, I told you it has also a bone marrow sparing effect and it also causes flagellate dermatitis and pulmonary fibrosis. So these are the important adverse effects of the various anti-cancer drugs. So moving on to the last question of the session is which drug is used for the treatment of trastuzumab resistant HER2 positive breast cancer. Breast cancers are very, very important for examination. So remember these breast cancers, there are 2 variants that we should know. One is the ER positive breast cancer and one is the HER2 positive breast cancers. In the ER positive breast cancers, we have, if either the case would be premenopausal cancer or it will be a post-menopausal cancer. So premenopausal cancer, the drug of choice is a SERM, which is tamoxifen, selective estrogen receptor modulator, tamoxifen. Then we have in the post-menopausal, the drug of choice in an aromatase inhibitor, which is called as N-astrozole or letrozole. These are the aromatase inhibitors which can be used. And now we come to the second part, which is the HER2 positive cancer. What if it is HER2 positive cancers? Then the drug of choice for HER2 positive cancers is a monoclonal antibody, trastuzumab. That is why it was given here, trastuzumab. But what if there is resistance to this? The second option in this is lapatinib. So tyrosine kinase inhibitor, lapatinib. Remember, lump in the breast, lapatinib. So that is the second. So here the correct answer is lapatinib. Now we have this page shows you all the others, whereas important, you can say the targeted therapies. Not all are important, but these are few of the important targeted therapies. So remember, we have here HER2 we've already talked about, HER2 breast cancers. Then we have the HER1. The HER1 receptors, they are usually involved with the HER1, if you write HER. H you can remember from head and neck cancers, head and neck cancer. E you can remember expiration. किसमें होती है? Lungs. So the lung cancer. And R stands for rectum, colon cancers. So these are the cancers where HER1 is usually responsible. So important drugs here, TKIs here we have for this. We have erlotinib, and at least these two are important, erlotinib, gefitinib. Now lung cancer, remember, lung is surrounded by the rib cage, so the mnemonic cage, which are the drugs which are important here, the targeted therapies, ceritinib, afatinib, gefitinib, and erlotinib. CML, remember, for CML, the drug of choice you should know, for CML, it is imatinib. Imatinib is also a drug of choice for GIST, gastrointestinal tumors. So remember, imatinib, drug of choice for two cancers. One is CML and the other is GIST. Now coming to here, PARP inhibitors. They are also used for breast cancer. So these PARP inhibitors will always end with PARPs, right? So PARP, कैसे याद करें? PARP inhibitors, PARP. Pari means, or you can say pari. Pari is female. So all the female cancer can be used. It can be used for breast cancers. It can be used for ovarian cancers as such. Okay, so it can be used for these type of cancers. So important cancers here for the exam should be, one is very important, breast cancers. Then CML has been asked, the drug of choice, imatinib. GIST, drug of choice again, imatinib. Then for the HER1, remember the lung cancers, the cage, one of them can be used. And yes, we have discussed all these important targeted therapies. So remember at least these few. There are many others, monoclonal antibodies, a lot of them, but at least these few have been asked quite often. And apart from this, also please do the immune checkpoint inhibitors. Right? So immune checkpoint inhibitors, that should also be done alongside. So with this, we finish with today's topic of the 25 most important MCQs in pharmacology. Thank you so much.